Welcome back to the Oncology Journal Club, your essential dose of the latest oncology research, expert analysis, and our trademark blend of healthy skepticism and bad dad jokes. Brought to you by the Oncology Network. I'm your producer, Rachel Babin, and I'm once again joined by our Journal Club hosting dream team, Professor Craig Underhill, Dr. Kate Clarke, and Professor Christopher Jackson. This week, we've got a powerhouse lineup. CJ has huge news. He has taken up the challenge of not covering GI this week. He takes us inside a compelling study exploring non-operative management of mismatch repair deficient tumours. Kate covers metastatic breast cancer with the MECA trial, and Craig walks us through not one, but two major updates to clinical trial standards. What's new, what's helpful, and what does it all mean for how we read and write trials? Of course, we've also got our signature quick bites, those curious, quirky papers you won't hear about anywhere else. You'll find links to all of the papers and the hosts' bios in the show notes at oncologynetwork.com.au. The Oncology Journal Club is proudly produced by the Oncology Network's podcast team. Thanks for tuning in. Let's get started.
Hey, g'day. Welcome to OJC Cross the Ditch. Hello, Dr. Clarke, how are you?
Kia ora. I am not blown away despite the 140-kilometre-hour winds outside my door.
Windy Wellington living up to its name. And Professor Jackson, how are you?
Yeah, I'm really well. Thanks very much, Craig. Kia ora, audience. Kate, I was hearing today that today was the windiest southerly in Wellington's history, which means that there's a northerly, easterly and a westerly which have been stronger.
There would definitely have been a northerly that's been stronger because, as you know, that is our predominant wind, but coming from Auckland at speed. But yes, it has been quite dramatic, and many of the coastal roads are closed.
Yeah. Well, we know the reason that Wellington blows is that Christchurch sucks.
I would have thought most of the hot air comes out of Dunedin.
It's just out of my house, Craig.
Where Professor Jackson is abiding.
That's it.
All right.
On to the data.
Yeah, so thanks everybody for recent feedback on the episodes. And it's good to know that someone other than my mother is listening. Professor Jackson, let me guess, something about GI cancer.
Oh, you gave me a total embargo on GI cancers this time, Craig. So I've got a couple of things which are non-GI cancer related. My main paper today is the non-operative management in dMMR solid tumours. This is just out in the New England Journal of Medicine, lovingly known as the Journal of Positive Results. We will all remember very well the dostarlimab story, which came out of the Memorial Sloan Kettering. Initially with 9 patients who had rectal cancer who had a year's worth of dostarlimab who had clinical complete responses. And then we saw the headlines, which were researchers have tears of joy at these wonderful responses based on 9 patients, and the standard of care being changed with such a small number of patients. A lot of hoo-ha. And was that an abstract? Was that the plenary at ASCO as well? I can't remember if it was the plenary or not. I think it might have been.
I think it might have been.
But it was a big deal, wasn't it, at the time? And particularly for a tumour type where all we were really doing was a modality shift. We weren't actually curing increased rates of people off that data. We were just looking at modality shift at that time. So the questions at that time were, was it actually going to be a durable response? Were you curing more people? Or was it around saving the morbidity of abdominal perineal resection? Turns out that particularly dostarlimab study was part of a bigger project. So they had a 2-cohort study, one for rectal cancer only, and the second cohort was for any patient with a localized, so non-metastatic, stage 1, 2, or 3, any primary tumour site with deficient mismatch repair as judged by immunohistochemical loss of expression of one of the 4 mismatch repair proteins. So it did not have to be microsatellite instability proven by NGS. It just had to be loss of expression of mismatch repair proteins, which is imperfect, but it's one we've got in routine clinical practice. This is in the background of neoadjuvant studies such as the NICHE study, which is one of Kate's favourite studies, which I think showed a 70% major pathologic response in people who just got a couple of doses of immune therapy, and the dostarlimab rectal study, which now I think we're up to about 30-odd patients in that study with 100% clinical complete response at 12 months. Don't have the long-term data or morbidity. And these patients, remember, with mismatch repair deficient cancer usually have a better prognosis than those with microsatellite stable. So for most of these patients, this is a non-surgical approach or a modality switch rather than necessarily a cure. And there's a very big difference in a right hemicolectomy from an APR. So the balance of risks and benefits in all tumours is not the same. So this is a phase 2 study at one institution. Patients with DMMR got 500 milligrams of dostarlimab every 3 weeks for 9 cycles, or roughly 6 months. Cohort 1 rectal, cohort 2 non-rectal solid tumours. And they were evaluated at the conclusion of their 6-month course of treatment and 8 weeks following. They undertook what they described as all feasible assessments, which would mean endoscopy if appropriate, and one presumes PET CT scan as well, but that was in the supplemental materials that I didn't dive into. The primary endpoint of the study was simply for the rectal cohort, not for the all-comers cohort, and the endpoints in the all-comers cohort was exploratory. So just to clarify, this is a phase 2 single-arm study with an exploratory endpoint in the New England Journal of Medicine. There is hope for my single institution studies yet. A Simon 2-stage design was undertaken. If 4 or fewer recurrences were noted, then the study was closed with futility. If 13 or more had clinical complete response out of 15, it was deemed a success and it was closed for success. And at the end of the 15 patients recruited in cohort 2, it was deemed a success as they stopped. They reported 54 patients in cohort 2. And 19 out of 54, so that's 35%, did not have a clinical complete response. So let's just make sure we get that figure clear in our heads. 100% of people with rectal cancer had clinical complete response, and only 65% of people with other solid tumours, 2/3, had clinical complete response of other sites. Now, of those patients, 16 of the 19 who did not have CCR went ahead with surgery, and 3 of 16 had nodal positivity with a primary complete response. So sometimes you might see, for example, a luminal complete response, but you get a nodal positivity. So just assessing the the primary site may not be sufficient. And the overall outcomes, the 2-year RFS was 96% in cohort 1, and in cohort 2 it was 85%. So again, that's not stage stratified, stage 1, 2, and 3. That's all comers, 85% 2-year recurrence-free survival. So not all patients who have DMMR tumours who get surgery, of course, remain recurrence-free at 2 years, and they can be salvaged with immune therapy at that point. But it does say that we can save about 2/3 of patients from an operation, but a third will still need to have an operation. So despite the fact that immune therapy has got a quote-unquote tumour-agnostic indication for DMMR tumours, this study still suggests, in my opinion, that this primary site of tumour does matter when you're advising people about whether or not you can undertake non-operative management. The 2/3 gives you a ballpark, but we need more information about the specific subtypes as to which tumours respond well and which primary sites do not respond well. But I think this does give appropriate caution and appropriate pause when we're thinking about charging down a non-operative route for all patients with DMMR cancers. This says that we have to be a bit more cautious than that, and we can't extrapolate those amazing findings in rectal cancer to every single other study. So great that we've got that data. It's a little bit more than we had before. Still looking forward to having even more and a really good set of data to have. In my practice recently, I've had a very elderly lady who had a number of comorbidities who had a DMMR colon tumour, and the operative risks were thought to be about a 10 to 20% chance of mortality. So she opted for immune therapy, and it's now good that we've got data where we can actually say what the chance of CCR is in individuals like that. But clearly not the right operation for everyone, not the right procedure for everyone, and there would be some tumour sites where I might still prefer surgery over 6 months or more of immune therapy with intensive surveillance. Kate, what's your take on that study? I know it was one that you read with interest too.
How do I put this in words after a day on the couch? My feeling is that DMMR-ness is different in each. Why our cancer has MMR deficiency seems to be different in each site. And we are still doing this as a massive cohort. So we're not thinking are Lynch-associated different, are sporadic different, are the different genetic mutations different. We know that you get heterogeneity in many tumour types. That was the gastric cancer trial we talked about last time. Does that explain all of it? Probably not. Or is it just that you need to give a longer time for some tumour types and a shorter time for other tumour types? Should we be giving dual antibodies? Because particularly the hepatobiliary ones, it's very immune cold. You wouldn't be expecting an anti-PD-1, anti-PD-L1 agent to act particularly well as a single drug in those sites. So it's so many questions out of this, but I think it is very interesting data. I am a fan of niche 2 because they all still get operations, and we do have a collection of people who would otherwise be inoperable who are then rendered, hopefully, in my tiny cohort, cured. So that's my take.
Yeah. So, I mean, in the rectal cohort, they were almost all Lynch patients, weren't they, Kate? So,
I was trying to furiously read that now to try and figure that out because they don't have the very obvious what you'd like to see, which is a mismatch repair gene with pathogenic Lynch syndrome associated germline variants, and then they've got gene, but you have to extrapolate out that 50% of them do not have a germline mutation, I think, if I've done the maths right. So it is a bit tricky to try and figure out who's who. Yeah.
In cohort 2, yeah.
So if it's possible for me to get a word in here, Chris, a couple of questions. So to me, it just sounds interesting data, thought-provoking, but clearly you can't make a decision on multiple tumours, the management of multiple tumours on the basis of 60 patients, even if it is in the New England Journal. And so that's a comment. The question is, how are you able to access the drug for the elderly lady with a high risk of surgical mortality? Was it, did you have to purchase the drug, or are you able to access it now?
Well, with my particular patient, she opted to self-fund in her instance, although if you've got rectal cancer, the company will give you dostarlimab if you've got rectal cancer under Access Program in New Zealand. In terms of is 50 or 60 patients enough data, Craig? I mean, I think there was extraordinary enthusiasm for rectal cancer non-operative management on the basis of 9 patients. So oncologists are not well known for undergeneralizing from early data. I think we're probably more known for overgeneralizing from early data. I would simply reflect that DMMR in different tumours is clearly different. And so you can't extrapolate from rectal. And like Kate says, I think you have to know a little bit more about the molecular heterogeneity and the origins of that and tease that out. Now, we know in advanced, remember when the very first data came out in DMMR colon cancer, that was from a basket study. And there were only about 3 or 6 patients with colon cancer in that study, I think, from recollection. And people were charging straight in. And it was a couple of years before we got Keynote 177, which was the colorectal specific one. So I think you have to be cautious. But people will always say, we will use the data that we have, and we will have evidence-informed practice rather than evidence-constrained practice. And people will make individual decisions with the patient in front of them, provided they are well informed of the risks, benefits, and alternatives. But that does segue slightly into...
Yeah, but there's like one patient with cholangiocarcinoma, so you think you know how to manage cholangiocarcinoma with DMMR now on the basis of one.
Well, I don't think so, Craig.
Good.
I don't think
okay. So. Let's move along. Kate, while you're lying on the couch, what have you been reading in your journals?
Yeah, look, I wanted to present a Chinese trial because it intrigued me. So from the sublime to the ridiculous. So I think Chris wants to spend, dostarlimab resale is about $250,000 a patient. So I want to talk about treatment-naive metastatic breast cancer using a combination of very low-dose capecitabine and an aromatase inhibitor versus the aromatase inhibitor alone. So this does fall into the trap of combination therapy versus sequential therapy, and they have a missing arm. Dr. Jackson, if you shuffle another paper, I will torpedo you from here.
Yeah. Chris, it's like the pandemic started 5 years ago. There's a button there that's got a little hash on it. It's the mute button.
He's too used to being the professor. Anyway, so a group of women, metastatic ER-positive breast cancer, they were either given very low-dose capecitabine, so 500 milligrams TDS, so 3 times a day, so 1.5 gram total a day continuous, alongside standard dose of aromatase inhibitor versus aromatase inhibitor alone. Doubles the PFS, curiously, doubles the 5-year OS, which I find fascinating, but then nowhere in the paper or the supplementary is there post-protocol treatment. So I can't see whether everybody got access to capecitabine, because it's a very standard, until we had CDK4/6, for people to have an aromatase inhibitor followed by capecitabine, and we know that capecitabine is very helpful in women with metastatic breast cancer, particularly hormone sensitive, but it is limited by toxicities at our standard doses. So I've moved in my practice to do the 1.5 gram BD week on, week off protocol, and is fantastic. Much easier to deliver than the 2.5 grams per metre squared, 2 weeks on, 1 week off schedule. The other thing I think that was great about this paper was not only was it done in China, but it clearly points out that CDK4/6s are still prohibitive for most of the world, and capecitabine is cheap as chips. So this is an alternative strategy. And of course, they're now muttering in their discussion about whether this can be moved into an adjuvant space. So I have questions for the authors, but I found this fascinating.
So, Kate, that dose, is there some randomized data comparing the two dose schedules and showing the equivalence,
Yep. So not this dose. So the dose I'm talking about, the 1.5 gram VD week on, week off, has been compared with the traditional schedule. It's more deliverable and it has a slightly longer PFS, but that's slightly probably because of deliverability. Women don't drop it because their hands are falling off. Yeah. No, I haven't seen this dose compared with anything else.
Good used in this paper. Yeah. So will you be changing your practice as a result, do you think?
Are we allowed to say things like this? I have sneakily once given somebody hormonal manipulation at the same time as capecitabine because she had her back against the wall and it was before CDK4/6s and she didn't do very well anyway. It was a sort of a Hail Mary. I don't know. I'm curious. I really am curious. I want to talk with some of my other breast cancer colleagues about whether they will be tempted to do this. In a New Zealand place, we now have 2 CDK4/6s reimbursed. So it's unusual that there would be a woman who wouldn't be appropriate for CDK4/6, for whom I would also think that capecitabine was a good idea. So I'm not sure where this would fit in my practice, but I do find it fascinating.
So Chris, if you touch that button again, it'll unmute you. Do you have a question?
Look, I've just been sitting here quietly off mute, actually, you would never know it. I'm a quiet little mouse. I thought you Aussies were used to full noise anyway. So, Kate, interestingly, the hormonal manipulation, that's supposed to stick cells into G0, right? So why does that work with a cytotoxic chemotherapy, which is about...
Well, there is a whole page in the article of the introduction trying to explain that to me in a way that I have to say I would need to read again to understand. So the idea is actually that metronomic chemotherapy, particularly capecitabine at these low doses, is not in fact acting on proliferating tumour cells. It's supposed to be acting as an anti-antigenic, anti-cancer therapy, promoting apoptosis of the cells within the tumour microvasculature. And I love the sentence, recent research works have also unveiled additional mechanisms. Full stop. So I think it works, but we don't know why it works, is the question.
Okay.
But also, again, I wonder about heterogeneity. If you take a breast tumour, you know that some of it is ER positive, some of it is not. Yeah. We don't actually know whether we're treating that, whether even our aromatase inhibitors are treating the cells that stained ER positive, or whether they change all the time. We suspect they change all the time.
Yeah. If it's on target or not, right, that is hard to know. But the great thing about clinical data is that's the final proof that it does work or not, which is what I love about clinical trials.
I also want to defend myself because it is a combination versus a single, but the OS is stonking. And so, no business about crossover or whatever. They just proved an OS. Which is odd because CDK4/6 has only just been able to prove some.
Ultimate endpoint, live longer, live better.
All right. Well, thanks, Kate. I'm going to change direction and go a bit lateral, which we like to do on this podcast as well. And I'm just going to highlight to people the new Consult 2025 statement, an updated guideline for reporting randomized trials published in Nature Medicine recently. And so the Consult guidelines are used for reporting randomized clinical trials, or actually not randomized trials, reporting all trials. First published in 1996, updated in 2001, 2010, and now in 2025. And so it's a framework for authors to report clinical trials. Some additions, there's a whole list, I think, of 34 checkpoints for people to tick off, a checklist of 34 things to include in your report in a clinical trial. And interestingly, some of the additions are really to open up and make reporting more transparent, to include more information about safety, reporting of potential harms to the subjects, including more clear information about comparator, the intervention, how the intervention comparator actually delivered, details about concomitant care, and importantly, some information about the statistical analysis. Sometimes that can be a bit unclear in reports, so there has to be some detail either included in the report or in an appendix, and some clear information about potential conflicts of interest. So I thought that was worth highlighting. There's a whole series of papers then that were published at the same time, some in other journals such as the BMJ, which were really commentary pieces or perspectives. Some talked about how the process of coming up with these guidelines, but an interesting comment in one of the commentaries about the importance of in the future of health research really depends on our ability to produce evidence that's not only innovative but also trustworthy. Reporting guidelines are pivotal to this endeavour. They not only improve research but also help to safeguard public health. And so by mandating their use, streamlining their implementation and investing in education and technology, reporting guidelines can be transferred from optional aids or administrative hurdles to essential instruments of scientific integrity. So really call for the major journals, or all journals really, to mandate the use of these frameworks to ensure robust, clear reporting so that people can trust in the information presented. So at the same time, another paper appeared called the Spirit 2025. And so this is a similar framework. And this time, this is a checklist designed to ensure robust design of clinical trials. So you have the Spirit for the design, the Consort for the reporting. And in a recent episode, Professor Jackson talked about common sense oncology guidelines. They're specifically for randomized clinical trials. And he also discussed, should any of us listening be asked to do a plenary presentation at ASCO on how to discuss randomized clinical trials at major meetings. So in the last couple of episodes, in the notes, people can reference these important frameworks for the design, reporting and discussion analysis of clinical trials. I'm sure Professor Jackson will have a comment.
My first comment is I'm just texting my daughter to say, turn off the music. It's really loud. So, look, I think reporting of clinical trials standards is really critical. The Common Sense Oncology group clearly acknowledged that gap and wanted to ensure that we were reporting trials in a consistent and standardised way. And that common tricks that are used to distort or massage data are exposed for what they are, and to assist peer reviewers in the process, also when things are done in a standardised way. When things are unstructured, then people will just use, made-up endpoints or intermediate endpoints or whatever, and we all suffer from the lack of high-quality data. I think that companies respond to the environment they're in, and the FDA has been lowering the standard for which they will accept registration of clinical trials, and their response is, well, look, it's not our job to gatekeep the evidence, our job is to interpret the evidence. And then journals say it's not our job to gatekeep the quality of studies, it's to report the studies that were done. And then ethics committees say it's not our job to gatekeep, and everyone says it's not my job, and it ends up being no one's job. We end up being in a very low, very low standard. So I think the answer to it is that it's everyone's job to make sure we have high quality evidence, and having some standards around that will be very helpful, or is very helpful.
So you agree with the move then to mandate the use of these frameworks in the design?
Yes, I do, actually, Craig. I really do strongly endorse mandatory reporting. We've got some standards like, mandatory use of consort diagrams for randomised studies, for example. When you're dealing with Indigenous data these days, we have something called the Consider Statement, which is developed in New Zealand by New Zealand Indigenous authors, which is a really useful way of looking at that. Having frameworks and structures, I think, is critical, and having agreed standards is actually very helpful for the community. The risk becomes a bit like guidelines, and then that is what if conflicts of interest permeate the standard writers, and so we have to be pretty careful about that.
And I think maybe the unintended consequence of some of these guidelines is they can be exclusionary by requiring a lot of resource-intense reporting and data collecting in a framework that maybe doesn't exist outside a very wealthy space. So that's just something that I think maybe people have to think about very carefully when they're authoring. But I will present one of the papers that I'm presenting falls into very naughty reporting, which I will leak shortly.
One of the interesting things in this updated guideline is to include information about in the design process how the community or how people with lived experience are actually involved in the design of the study. So that's a really interesting twist. And, in the past, I think the medical community and sponsors have perhaps been a bit fearful about that involvement, but I think that we've learned to understand that can actually make the studies much more robust and common sense and practical real world once they've actually conducted.
Common Sense Oncology has also drafted a patient values and principles for conduct and design of clinical trials. And one of the major values that we've got at the front of that, Craig, is that patients must be involved in the determination of inception and design as well as conduct. And that's because how do you know that your study is actually going to answer a question that matters to patients and people with lived experience without actually asking?
Yeah.
And so I think it is important that people with lived experience are involved. That's easier in some tumour types than others. For example, pancreas cancer, which has got a very high mortality, is quite hard to engage people with lived experience, for example. So that is difficult. But it doesn't necessarily have to be tumour specific, I would suppose.
Kate, I think you've got a couple of quick bites.
I do. We all love a guideline, and I want to draw your attention to the recently updated fertility preservation in people with cancer guideline published in March, I think, of this year. Very thorough, very useful to remember that all people deserve a conversation about their fertility alongside a conversation about their cancer treatment. Get across it, as the Australians would say.
Yeah, I did see that, Kate, and I thought about putting on. So I'm glad you chose that. Was there anything particularly new, or it was really just a summary of the current literature and a reminder that we should have those discussions?
Look, I think it's useful in that it has a lovely title with the method of, particularly for women, the method of fertility preservation, the clinical pregnancy rate expected, the live birth rate expected, the miscarriage rate expected. So you can have an informed conversation with somebody, but this is effectively a second FSA, a first specialist assessment. This takes a lot of time.
Yeah.
And we're lucky enough in Wellington to have a couple of really interested fertility clinicians who will have this conversation for us. But this is a useful base to start having those conversations. The other one that is coming, because I've just been asked to submit on it, is the cancer in those who are pregnant, which I think is going to be really, really interesting when that comes out. They're asking some really in-depth questions, which I thought was really cool. The other quick paper, the one that's naughty, is the Palmyra. So Palmyra is that you keep somebody on palbociclib after progression but change the hormonal therapy. It doesn't work. It was never going to work. I don't know why the fuck we decided this was a good idea. But anyway, it doesn't work. So stop doing it.
If anyone's doing that, don't.
That harks back to the days of bevacizumab beyond progressive progression.
Oh, drives me nuts. Anyway, and then my last paper is the long-term data, the final overall survival from Falcon, which is fulvestrant versus anastrozole. Look, fulvestrant is a fantastic drug, except for the fact that it is IM, intramuscular. And if it had been invented before aromatase inhibitors and tamoxifen, everybody would be using it left, right, centre, but we're not. The final OS is women, particularly those that do not have visceral disease, who have metastatic ER-positive breast cancer, do very well on either indication. But listen to this very naughty, and this is why I want to draw your attention to it. Among patients with non-visceral disease, a trend towards a 15% reduction in the relative risk of death with fulvestrant versus anastrozole, median OS 65 months versus 48 months, in brackets, hazard ratio 0.85, confidence interval 0.6 to 1.2. That's in the abstract. So I think they need to read a consult.
They do. Or common sense, or...
Yeah.
Chris, did you have any...
On a couple of wee quickies, again, to try and respond to my challenge, Craig, not to resort to GI.
Wing?
Wee quickies. Hang on.
Is that a brand of biscuits or something?
Quick bites. It's like snacks, like canapes. We call them the canapes of oncology. And so one of the papers I wanted to cover very briefly was a paper from Harvard, from the Journal of Oncology Practice, just from a month or two ago, which just looked at the patient and caregiver experience with hope and prognostic uncertainty in immune therapy. Now, I think this is an incredibly difficult clinical scenario where you have people who have, for example, advanced melanoma, who have a PD-1 inhibitor which occasionally cures them. For most people, it remains palliative, so it's life-altering, so can cause temporary tumour response, and many people it doesn't work at all. But what people often hear is the potential cure in that situation. And these are people often who've got heavy disease burden, whatever, and we've all seen the miracles, who've got anchoring biases towards the fact that sometimes patients are cured. And of course, it's painful to talk to people about the fact they've got incurable disease. So what do? Oftentimes the temptation is to talk up the word of cure. In that situation. So I find this a challenging situation, a drug which has got occasional cure but usual palliation, and how do you frame that conversation well? This particular study interviewed 42 patients and 10 caregivers who were receiving immune therapy either for non-small cell lung cancer or melanoma, who are receiving immune therapy, and the melanoma could be either adjuvant or curative intent. Now, they found 4 fascinating themes, the first of which I think is the most important one for this, and that is that the oncology team shaped the patient's hopeful expectations of immune therapy as a potential cure. So most of their excess hope is actually coming from the clinicians. So even in the Google era of medicine, they're still getting their hopes and expectations shaped by the clinical team. So it remains our job to ensure that we communicate that well. And then, unsurprisingly, that followed on from that, distress related to prognostic uncertainty, particularly amongst those who experience toxicity. So once patients get toxicity, they find that very distressing when they come off the immune therapy, particularly if they think it's a curative intent drug. And then when they do progress, patients that nevertheless progress in more than 2/3 of people on melanoma therapies, they experience, quote unquote, overwhelming disappointment. As well. So we're doing a lot of emotional harm to people by the way in which we frame the discussion. So we have to, I think, do more work in how we frame our discussions in this group of patients who are facing this very difficult conundrum between occasional cure but usual palliation, and how we do that well. So we have 2 wise oncologists on the call and also me. So Craig, in these contexts where you have that kind of prognostic uncertainty, what methods do you use to convey that type of uncertainty to people in that context?
That's a really deep question. There's this landmark paper called Hope and Optimism in a randomized trial of chemotherapy for metastatic colon cancer with co-authors Craig Underhill, Tim Price, Neil Tebbett, Nick Pavlakis, Michael Jeppard and others. Yeah, so it is a really difficult space. Many oncologists would probably tend to overestimate benefits and give people false hope, but there is an association between hope, optimism, and then anxiety and depression, and so it is that balanced conversation. I think it's a really difficult space. I'm not sure how to answer your question directly with what tools I would use. Was that what you asked me, Chris?
Yeah, what's your clinical approach in that situation where you have the occasional patient cure, and you've got those anecdotes of extraordinary outcomes, and how you balance that hope against the reality for most people it remains incurable?
Yeah, I think you just have to have an honest conversation, and you need to be careful in the use of the language, and you need to talk about absolute benefits rather than relative benefits, which I think confuses people, and make it very clear that you're trying to control and slow down the cancer and not aim for cure in the palliative setting. Kate?
I think things have got more complicated with that dangle, because when we were just having the good responders and the poor responders, you could always say, I'm not going to make this cancer go away, but we're going to buy some good quality time. And that's really, straightforward sentence. I do like the work that Belinda Keeley and Martin Stockler have done about best case scenario, worst case scenario, usual scenario. So and at which time point we will know what your trajectory is, so that people can plan. I think that's probably the best framework I've seen. I don't know, has anybody seen anything that's easier than that?
That's the one I use, Kate. It's one I teach medical students, good case, bad case, typical case. The problem is, I think that people's understanding of their outcome changes over time, and sometimes what you think you say and what people hear are different. And so checking in with people regularly about what they understand their prognosis to be. I mean, other studies demonstrate that even when you tell people they're being treated with non-curative intent, that after a while a not insignificant proportion think they're curable, so people's understanding of their prognosis changes over time. And once you know that data, it suggests that it's mandatory on us to re-check in with patients about their understanding on a semi-regular basis, which again, as I say, it's an uncutful thing to do, but the data says that it's important.
In the right patient, it can be done in a gentle way, just check it in, I have a couple of hilarious, particularly men patients, so I'm like, yep, just so you know, You're still dying, but not today. So it doesn't all have to be doom and gloom, and it's about building that longitudinal relationship, which is why we wanted to be medical oncologists, because you get to own your patients and build that relationship.
Well, perhaps not own them, but have a long-term
relationship. Yeah, it's not quite the right word. Long-term relationship.
Have a long-term, and I think you're absolutely right, Kate. And I think the other bit of wisdom that you just snuck out there as well was the importance of including your personality and maintaining a rapport with people, right? Understanding your relationship with them and knowing the style of communication that an individual knows and will tolerate and will feel comfortable with. And so personalising your communication style with the individual, which when you do have that long-term relationship with people is just so much more possible. And it goes to show again and again and again that oncology is not a transaction, it's a relationship. And that is the beauty of the profession.
Okay. Chris?
Yeah, look, I've got so many quick bites, Craig, just so many, and so many non-GI quick bites as well. I mean, I do read about something other than colon cancer occasionally. I know you don't believe me, but I'll save them all up for next time.
Oh, okay, good. Can I move on to mine?
Please.
I've grabbed a few things from the AACR meeting, and no, I didn't go and don't want to go to America at the moment, but there was some good stuff and maybe practice-changing stuff in there. Firstly, in head and neck cancer, and, we don't often have a paper on head and neck cancer on the podcast, but this was done in patients with locally advanced stage 3 or stage 4 head and neck cancer. So locally advanced stage 4 refers to when the tumour is extended out into adjacent tissues but not metastasize. And this was adding doses of pembrolizumab to standard of care. So the standard of care in these patients can be definitive chemoradiotherapy or can be some surgery, and then depending on the extent of nodal involvement or extranodal spread, can be chemoradiotherapy or just radiotherapy subsequently. So this was adding neoadjuvant and then adjuvant doses of pembrolizumab to the standard of care, whichever was determined by the investigators. It was a big study, 363 patients, was conducted from the end of 2018 to the end of 2023. This is being touted as probably the first change in standard of care for these group of patients in the last 2 decades. And it showed an improvement in the pathological complete response rate in people who had had preoperative pembrolizumab. It showed an improvement in event-free survival and also overall survival. So there was a concurrent publication in the New England Journal. So we'll put a link to the abstract for that paper. So you guys probably don't treat head and neck cancer. It's very much treated by a group of multidisciplinary team, but within your centre, it'd be interesting to know whether, if the drug's accessible, whether they also consider this to be a change in the standard of care. But that was very much the commentary around that paper. There was another paper. This was simultaneously published in the New England Journal. I'm going to have to practice saying this name. This is zongertinib in previously treated HER2 mutant non-small cell lung cancer. So that's about 2 to 4% of non-small cell lung cancer are HER2 mutated. This is an oral irreversible HER2 selective TK inhibitor, previously shown to be efficacious in phase 1. This is from the phase 1B. So this is drug given 120 milligrams a day. It showed 71% of these patients had an objective response in this phase 1B study with a median duration of response of 14 months, median progression-free survival of 12.4 months. So this is a space that's free of a standard of care. And so while this is only a phase 1B, and we'll obviously move to further studies, there's a lot of hope around the ability of this drug in the future to be, potentially a new practice-changing treatment. So currently in the US, they have the antibody drug conjugate trastuzumab deruxtecan, which was one of our previously favourite names of new drugs, but maybe that's going to be gazumped by zongertinib in this group of patients. We will wait and see.
I don't treat lung, and this concept of HER2 mutation as opposed to HER2 overexpression is very lung specific. It makes more sense to me that a tyrosine kinase inhibitor would work better than trastuzumab deruxtecan, which is a delivery mechanism, effectively, rather than an anti-HER2 agent. So where does this unpronounceable medicine...
Zongertinib.
Yeah, what does it do? Where does it work?
Well, if it's a TKI, it's probably intracellular. It's going to be the downstream pathway of the HER2 on the MAP kinase pathway, I presume.
And one would assume it's mutation specific, or so it's only going to take out mutated cells?
Okay, don't ask me too clever.
Okay.
It just says it's an oral irreversible TKI that selectively inhibits HER2 while sparing EGFR, thereby limiting associated toxic effects. And a couple more interesting things from the AACR. There's another paper. This was a Key Link 007 tumour agnostic trial of olaparib plus pembrolizumab in homologous recombination repair mutation and homologous recombination deficient positive advanced cancer. So it was a tumour agnostic study, so combining olaparib with pembrolizumab, and they broke down the results into those patients who had BRCA1 or 2 mutations or non-BRCA repair mechanism deficiencies or mutations. The results looked better in the BRCA patients with a response rate 36%, disease overall response, progression-free survival of 4 months, median overall survival of 14 months. So certainly looking like an active combination. So it's interesting. This was done in a broad range of cancers. Interesting to see this idea of combining two different classes of agents, but obviously we need to wait for more clinical trials to see if there's a trade-off not only in cost but also extra benefit over and above treating these patients with just the olaparib, but there's certainly a suggestion that these results are superior to the single agent drug alone. And then we haven't had a PBS update for some time. So I just thought I'd mention, again, this is a mutation in lung cancer. And this on the PBS in Australia just recently was announced that amivantamab, it's a bispecific antibody that targets both EGFR and MET receptors, which are often overexpressed in EGFR exon 20 insertion mutations. So these are for those group of patients. It's about a 12 to 14%, I think, of lung cancer. So not an insubstantial number of patients. And so this is giving this antibody in combination with chemotherapy, the basis of study previously published in the New England Journal in October 2023. And we'll put a link to that, but that drug is now available in combination with chemotherapy for patients with advanced non-small cell lung cancer with EGFR exon 20 insertions. And I'm guessing not in New Zealand just yet.
No. By and large, targeted therapies with small populations take a very long time to make their way through our processes.
Yeah. And I'm trying to think, but this is potentially the first bispecific antibody available on the PBS, certainly for solid tumours in the Australian setting. So some interesting stuff from the AACR. I also noticed in the plenary on innovations, they gave a plug for teletrials or decentralised clinical trials, as they like to call it. So interesting that at a plenary about medical innovations in cancer, they mentioned that the telephone and Zoom calls were a mechanism and an innovation to bring trials closer to home for people.
Well, no trial is useful unless patients can access it. So travelling is expensive.
Exactly. All right. Well, thanks, Chris.
Oh, fantastic data there. Thanks, Craig, and good to see some cool stuff coming out of AACR.
Thanks, Kate.
No, mate wa, keep warm.
Thank you, Rachel.
Thanks, team.
And we'll see you all again soon.
Thank you for tuning in to the Oncology Journal Club podcast, proudly brought to you by the Oncology Podcast, part of the Oncology Network. For healthcare professionals seeking regular news updates and insightful discussions, we invite you to join our community at oncologynetwork.com.au. Your free registration includes a complimentary subscription to our weekly publication, the Oncology Newsletter, a valuable resource to stay updated on the latest advancements in the field. We value your input and welcome your feedback and paper recommendations via our social media channels, email and website. Your insights help shape the conversation and drive the direction of future episodes. This is Rachel Babin signing off for the Oncology Journal Club podcast.